During World War II, it was called combat stress disorder or combat stress reaction. And then here lately, we have another description that's called post-traumatic slave disorder, and it describes the trauma that was inflicted on Africans that were brought over to the America or as slaves and their descendants. So as we know, it is natural to feel afraid and to have a trauma response, about the fight, flight, or flee response, and that's supposed to help us avoid potential danger. And as we all know, again, everyone will react to trauma in a different way, and that not everybody who experiences trauma is going to develop PTSD, and that everybody doesn't respond the same to the same stimuli. You have two people that experience the exact same situation, and one person is going to react totally different than the other in most cases. All right. Anyone can develop PTSD at any age. So women are more likely than men to develop PTSD. And I wanted to let you all know that PTSD is not inclusive to combat veterans, but it is widely associated with those who have been in combat or military service. According to the National Center for PTSD, about 7 or 8 of every 100 people will experience PTSD in their lifetime. And there are certain aspects of traumatic events that have some biological factors that make some people more susceptible to developing PTSD than others. Okay, so what are some of these symptoms that we're talking about? We're talking about feeling highly stressed, afraid, feeling like you're in danger, an increased fight or flight response. The symptoms must be severe enough to interfere with that person's daily aspects of living. And what really we want people to know about this is it needs to be diagnosed by a mental health professional. You're talking about a psychiatrist, a psychologist, a social worker. These people are going to experience disturbing thoughts and feelings, and be very confused about the things that they're going through. So this is why we're asking that, trained professionals make the diagnosis and help to take care of individuals that have the PTSD diagnosis, because it can be a little tricky. All right, so what I want you to remember about PTSD, the acronym that I learned, the acronym is trauma. So you need to remember there has to be a traumatic event. There has to be a re-experiencing of that traumatic event. There has to be an arousal, hyperarousal, an increase in arousal. There has to be an inability for that person to function. Then it says 1 month. I know that says 1 month, I'm going to get to it. And then there has to be some type of avoidance that comes along with that. And if you remember that acronym this way, then it'll be easier for you to make your diagnosis for your patient. All right, so there are 8 criteria that we're looking at. So we're going to go through all 8. And what we just talked about, there has to be exposure to a traumatic event, and that is required for signs and symptoms. And it must not have been whatever the behavioral issue or physical signs and manifestations, they must not have been present prior to the event, right? So a traumatic event is anything that we would consider to be violent, threatening to that person, and it's going to evoke feelings of fear, helplessness, terror in the person who is experiencing that. So when we're going down to criteria number A, there has to be at least one thing from criteria number A has to occur. There has to be a direct exposure. That person has to have witnessed the trauma or learned of that trauma from someone else, or indirect exposure can occur from being a service provider. So when we're talking about direct exposure, we're saying we've seen, that person has seen someone who has died. That person has been physically harmed in some type of way. When we go down to criteria number B, it's an unwanted or unsettling memories. We're talking about nightmares, flashbacks, emotional distress after exposure, or in a reminder of the exposure, or a physical reaction after exposure to that trauma. And that trauma has to be persistent, and that's where the re-experiencing comes in. And when we're looking at criteria C, there has to be one of those, and that has to be a trauma-related thought or feeling. So there's some thoughts or some feelings that are going behind that, and they're very intense. And then there may be some type of reminder that is associated with that. And I'll talk more about that. You have to have at least 2 of criteria D, the inability to recall key events from that trauma, over negative thoughts or assumptions about yourself or the world around you, exaggerated blame of yourself for causing that trauma or someone else for causing that trauma, a negative affect or effect that is around your environment, decreased interest in activities, feeling isolated, or difficulty experiencing positive affect at all. All right, so when I'm talking about re-experiencing, give you a couple of things to think about. 20% of our soldiers who are exposed to combat do develop PTSD. And 60% of non-service members, or what my father would call a civilian, my father was in the Marine Corps, will experience at least one traumatic event in their life. So that's about 8% of the population that may develop PTSD. People with PTSD, as I've said, you have to be the traumatic experience, and then the next criteria is they re-experience that trauma. Primarily, it's going to be a sudden onset. There's going to be some type of flashback where they believe they are in danger. They think that they're being threatened, and then that threat is in the here and now. So say, for instance, that traumatic event happened a month ago or 2 months ago, but that particular person that you're looking at right now, they hear a sound, smell something, see something, there's some type of trigger, and now they believe that threat is occurring right now, again, to them. So someone that's in the midst of a flashback, they tend to experience something, the experience is highly emotional and it's very sensitive. The senses are very heightened, smell, touch, taste. That's another reason why I was explaining it the way I was just saying it. There may be a sound, a touch, something they hear that really triggers that PTSD response. Another thing that you'll see is that the patient will experience nightmares and they'll have difficulty sleeping. And most times those nightmares are going to be related to that trauma, but not necessarily. Sometimes those people wake up and they don't know, they just know they had a nightmare and they're terrified. Sometimes they can recall what they're terrified of and sometimes not. But 70% of PTSD patients do report having frequent nightmares. And like I said, sometimes they remember the content of their dreams and sometimes not. But you will find that PTSD patients do have difficulty sleeping. And sometimes they have anxiety related to going to sleep. And so sometimes they will try not to sleep. And then that causes all types of other residual issues because they are in a heightened state of awareness. They don't want to go to sleep because going to sleep means that they will associate sleep with that PTSD experience. And so they would rather not. And then they, of course, as you can tell from the way I'm talking about it, there are all kinds of physical signs and symptoms of stress that are associated with that. Okay, so there's going to be avoidance. It can be a physical avoidance, meaning they're going to stay away from certain places. Say, for instance, if it was a car accident, they may not want to drive car or be in a car. When my grandmother had her, my grandmother was blind and she was in a car accident, and she was sitting in the front seat, and she would never sit in the front seat ever again once that car accident occurred. And so that's a example of a physical avoidance. She never wanted to sit in the front seat. As a matter of fact, she didn't want to travel in a car for a long time after that. But there could also include some psychological avoidance where this person is trying to numb the emotional effects of how they're feeling, because that's going to help to protect that person's brain. And what sometimes will happen with the brain is if you're having a intense emotion, your brain will literally shut itself down to protect itself. Now think about this: if you go for a long time without sleep, if your body goes a long time in heightened stress or in heightened anything, your body will literally shut itself down to protect itself and put itself in kind of what our computers do, kind of like in a nulling state to make sure that it protects the rest of the body. Well, your brain will do the exact same thing. So then the numbing causes a flattened affect for some people. So, the happy, sad range of emotions, you usually don't see that sometimes when people are having difficulty with PTSD. They're very null about how they talk. Their affect is very flat. Then this is where the desensitization and dissociation comes in, because that person doesn't want to feel what they're feeling. They don't want to have those thoughts. So they're going to cut it off. Whatever that feeling is, they're going to cut the feeling off from the thought. They're going to cut the thought off from the body so that they can survive. Again, like I said, when your brain is in a heightened sense of hypersensitivity, it will shut itself down to protect the rest of the brain, to protect the rest of the body. It is a primal response for us as Homo sapiens. So this is another reason why we ask that only clinicians, psychiatrists, psychologists, social workers, clinical social workers make diagnosis and provide treatment for people, patients with PTSD, for all the reasons that I just explained. Sometimes you can see some physical symptoms that will come out because people will start fighting, or they will try to defend themselves depending on what situations they've been in. So as a clinician, sometimes when you're having a conversation with your patients, you can just ask a couple of questions like, have they ever felt that their life was threatened or had any violent events that have occurred that they can remember? And sometimes that will trigger them to, let you know, hey, this has happened to me, or this thing has occurred. And with those answers, you can further explore with that person. Sometimes your client will just tell you, I feel like this traumatic event has happened to me, and then you can go from there too. The cognition and mood, we're talking about trouble remembering key events, negative thoughts, distorting events and feelings, putting blame on other people or putting blame on themselves, loss of interest in previous activities. Some of this looks like depression if you think about it. Some of it will look like depression. But some of the key thoughts about this is PTSD has emotional, depressive, anxiety, and stress-related intensive thoughts and actions that are connected to it. All right, we're going to go back to criteria. So for criteria E, irritability or aggressiveness, they're making risky behaviors, hypervigilant, heightened startle reactions, difficulty concentrating or sleeping, something that I mentioned. You have to have at least 2 of those that are occurring with your patient to make the diagnosis. So the other 4 that we talked about, right? And these are the second set of 4. You have to have 2 from criteria E. Criteria F, by definition, PTSD is a chronic disorder, meaning that the trauma-related symptoms must be present for a certain period of time. So this is where that 1 month came in that I was talking about earlier that I said I would tell you about. This doesn't mean that the symptoms have to be present in the first month after the trauma occurred. It just means that it has to have occurred for a whole month. So within these criteria, 2 of A, 2 of B, 2 of C, 2 of E, and so on and so forth. A delayed response of onset is usually mostly characteristic of PTSD, and 80% of people who receive the diagnosis show no symptoms within the first maybe 3 weeks, and then boom, there it is. So we're looking at criteria G. Symptoms create distress or functional impairment. So what we're talking about here is this person is not able to work. They are having problems parenting. They're having issues in their relationships. If somebody has experienced child sexual abuse or domestic violence, they may not want to have sex with their new partner. They may find it repulsive to see themselves naked or to see someone else naked, just to be frank with you. The re-experiencing hyperarousal and avoidance patterns can be impairing to people. And so, that's another reason why we ask that clinicians work with individuals with this. So in criteria H, be very careful. These symptoms cannot be due to a medication or substance use or other illness. So it can't be a result of them taking, I'm just throwing something out there, Prilosec. It can't be a result of someone being on some type of street illicit drug. It can't be that. That's not a part of the criteria. If it is, then it rules out all the other things that I just talked about, and then the diagnosis is not PTSD. The hyperarousal, I'm going over it again because I'm wanting to drive home the fact that these people feel like they are afraid. They are very afraid, and so there's a constant switch on for these people of being in this anxiety, stress state. It can lead to feelings of feeling angry because you're so stressed, you're angry. Like, why can't I get out of this cycle? Why can't I just eat? Why can't I just sleep? I can't concentrate. And so people start to have increased awareness of that anxiety, and then that anxiety brings anxiety on top of that, and that is what we're calling hyperarousal. And what you will also see is, for example, service members or those who've been attacked or had some type of been in a situation where it's been violent, you'll see something like this. They'll walk into a room and they will not sit with their back to the door. And usually that's a good sign that someone has been through a traumatic event. That is a hyperarousal symptom where I don't trust the people around me. So I'm not going to trust you to watch my back. I'm going to watch my back. I'm going to put my back to the wall so I can watch everybody else in here. So that's going to be a persistent, ongoing thing. And that's a chronic manifestation of PTSD. Okay, so remember I was talking to you earlier about disassociation. So there are some qualifiers or some specifiers that can go along with PTSD, and disassociation is one of them. Remember, I told you what your mind will do to protect itself is it will cut off, it will shut it off. It will take, the brain will disconnect its mind and body from one another so that it can survive. So that's where you're going to get the disassociation or the depersonalization, where people are saying, you know what, I look in the mirror and I don't know the person I'm looking at. Like, things don't feel real, things don't look real. These people sometimes have issues with connecting emotionally with people, because basically what I'm telling you is that to survive that traumatic event, they had to disconnect their body from their mind in order to survive whatever it was that they went through. And so I wanted to make sure that I told you that full diagnosis of criteria for diagnosis is not met until at least 6 months. There have to be 6 months of these things that I've already explained have been happening since onset. So 1 month they have to have had it for at least 1 month or experienced it for 1 month to even consider the diagnosis of PTSD. If they have experienced these things for at least 6 months, then we're going to provide the diagnosis of PTSD. All right, so about our kiddos, how do children and teens react? Not like adults. You should not expect children to react to any type of trauma stimuli the same way that you would an adult. It's not going to look the same. It may look like ADHD to some people. It may look like a regression, developmental regression. They're going to be acting out maybe, or you may have a child that will decide that they just don't want to talk anymore. And we used to call it selective mutism, where they just choose not to talk anymore. That is kind of like a manifestation of the dissociation, where the mind disconnects itself from the body. Well, sometimes children decide, I am in so much terror, I just will not talk. Or the last time I talked, it caused this issue or this trauma. So they connect the talking with the trauma, they won't talk anymore. Or you might see a small one that has bedwetting, or they start sucking their thumb again, or they're crying. It's very intense for children. And what they really need is a lot of support from family and friends and the mental health professional that they're working with. All right, co-occurring conditions. So most people with PTSD, about 80%, have at least one other mental health diagnosis. And so treatment for these conditions can help with recovery from that trauma. They are also at risk for functional impairments like reduced quality of life. You're going to be looking at panic disorders, depression, some physical symptoms. Then there's that cognitive dissonance that I wanted to talk about, where what you believe and what you do don't match up. And this is something that happens a lot with service members who go over to war, go over to another country. They don't believe in harming or hurting or killing women, children, fill in the blank. And they have to do that in order to survive. Well, that's cognitive dissonance, where you hold one belief, but you have to do another thing in order to prevent some type of issue from happening. When someone does something that goes against their beliefs, that's what it is. And sometimes this happens when young ladies have to fight their way out of situations, maybe a domestic violence situation, or they have to, use physical violence to protect themselves. All right. So why do some people develop PTSD and others don't? Pre-existing mental health disorders, poor social support sometimes, but not everyone who lives through a dangerous event develops PTSD. I talked about that earlier. There are some risk factors that may increase the likelihood of developing PTSD, meaning chronic exposure to dangerous events or dangerous traumas, or living in dangerous neighborhoods, seeing other people get hurt repeatedly, not having a strong support system, having a personal history of family trauma, or mental health issues or substance issues can increase that risk factors. But there are some things that are resilient about us all, and that is having a support system, family, friends, having coping strategies that are already in place to help us deal with those traumatic events. So other considerations, the nature of the trauma is as important to consider as anything else. Less than 10% of people who experience a non-intentional trauma, like a car accident, develop PTSD. But in contrast, about 50% of those who experience an intentional trauma, like an assault or a rape, will
Excuse me, Dr. Brown, you've been muted. I apologize. That was my mistake. So you need to unmute. There you
I
go.
did it. Okay,
Thank you. My bad.
no problem. I wanted to mention that the unexpected death of a family member or a close friend due to natural causes, the DSM-5 does not recognize PTSD. We usually give the diagnosis of someone having some type of grief or bereavement, but PTSD would not be the correct diagnosis for that, according to DSM-5. Those associated with intentional traumas like assault, some usually remain constant for a long time. So there's usually like a drop off, and then it'll remain constant. And if gone untreated, so say maybe something that happened in childhood or something that no one ever told anyone about, usually that PTSD response is chronic in about 50% of those who are diagnosed. All right, so the recipe, right? So it is important for anyone with PTSD symptoms to work with a mental health professional if they wish to. We would hope that they would. And someone that has experience treating PTSD. So here's my formula. Therapy, this is what I tell my patients. Therapy is great. Therapy is the gold standard. Medication usually is needed for some. Therapy plus medication equals a game changer for most. And doing nothing is a recipe for disaster. All right, so what therapies work? Well, EMDR is one that is not necessarily new on the market, but one that is talked about a lot. It has to do with reconnecting the mind and the body together. This is why I hope y'all can see me, there's a lot of tapping that is done with a person when we're talking about their feelings, because what you're doing is your brain is going to, your brain can do a lot of things at one time, like you can walk, talk, chew, and do all kinds of stuff at the same time. So what you're asking your brain to do is reconnect the mind to the body. Remember what I told you about dissociation, and that when your brain is overloaded with trauma, it will connect the mind from the body. Well, EMDR is supposed to be helpful. I know you're like, why is she tapping herself? But it's supposed to be helpful to reconnecting whatever you're saying that you're feeling, whatever you're experiencing, whatever you're talking to that therapist about. You're saying that and you're touching yourself. You're trying to reconnect the mind to the body. And EMDR takes several sessions for things to manifest themselves, but they have a lot of good results with EMDR and with trauma-focused cognitive behavioral therapy. There are a lot of good therapies out there, but those gold standards would be talk therapy, trauma-focused CBT, and EMDR. All right, medications. There's a lot of those out there that are prescribed to treat PTSD. Usually what they're looking to, you can't get rid of PTSD with medication. What you're trying to do is lessen the symptoms. So the fear, the anxiety. So what you're trying to do is lessen the chemicals in the brain that cause the fight, flight, or flee responses, the fear responses, the anxiety. So that's where the SSRIs come in. That's where the beta blockers come in. Effexor is one that's used, is the MAOI. And the military doesn't like to use it much, but outside of the military, it's used a lot. There is one medication that is, we don't like to use it because it has toxicity of the liver. And that's something that, you know, they would have to like do charcoal to bind it and get it out of your system, things like that. So it's usually not used as much. But other medications can help to address specific symptoms like sleep problems and nightmares. So all of the following prescriptions have serious medical outcomes, and sometimes the benefits outweigh the dangers. And this is what doctors always say, well, you know, sometimes the risk outweigh the benefit, you know, the benefits outweigh the risk of you taking it. Well, there's some things that they found through using anticonvulsive medications or other medications that have been used. That's like, oh, well, this works well for anxiety, or oh, this works well for sleep, like Depakote. Well, Depakote is used for something totally different in the mental health world, but it requires monitoring if you're going to use it for PTSD, because it can cause liver failure and liver function testing to be skewed. So you really don't want to use that if you can get away with not. Topamate or Topamax is one that is used for migraines, but it's also used in some instances for PTSD. But Topamax or Topamate has a higher increase of glaucoma, sedation, dizziness, and ataxia. So they try to stay away from using that too.
Excuse me, Dr. Brown, we have a couple of questions for you. One is Jennifer Calder asked, what medication is the one that causes liver toxicity? And I believe she means from the previous screen.
Let me back it up one time for you.
Yes, what medication is the one that causes liver toxicity? I guess among the
Nefesidone.
Which one?
It's the nefesidone. It's right up under
Surzones or whatever. Okay. And then
it's this one right here.
Yes, ma'am. You said it better. And Darla Dean is asking, does an Effexor cause HTN in some users?
Does it? Yes, it does. That's why they always tell you that the doctors will always tell you that, well, you know, the benefits outweigh the risk. So this is why I'm prescribing this. But they know that some of these medications have some really bad side effects. I guess I will use bad, yucky side effects. Say, for instance, Effexor. If you just stop taking Effexor after you've been taking it a month or two, you'll have something called brain zaps. And what that looks like is, have you ever been watching TV? And this is going to look weird, y'all, so just know I'm about to move my screen. And you ever been watching TV and like that? Well, then that's what the person sees, because the brain, what you're doing is you're taking a medication that has stabilized the brain and the brain chemistry. You just snatched it away. So once you snatch it away, the brain is an electrical muscle. And so you're asking the brain to rewire itself again, and you've taken away the stimuli that it was using. So you're going to have a lot of things like brain zaps. Some people have, they start stuttering, or they have, well, it's called TD now, but I knew it as tardive dyskinesia, where there's like jerking movements that occur because, like I said, the brain is an electrical muscle. And once you take medication away without titrating it off, meaning a little bit at a time, you can actually rewire your brain in such a way that it will malfunction in some ways. Did I answer a question, you think?
It did, and she had a follow-up. Is that why the military prefers not to use it?
I think that's why a lot of service members do refer not to use it, because there is a high prevalence of people in mental health patients who decide, okay, well, now I feel better. Now they have the therapy going, they have the medicine going. They're like, okay, I feel better. I don't need to take this medicine anymore. And then they don't take it. And then this happens. I know, I'm sorry, but that's the only way I can explain it to you. That happens, or they can start shaking, or they get cold sweats, they start having withdrawals. So yeah, that's a reason why, because then once you have withdrawals that happen, then we're in a whole different ball game. Let's see. All right. Sir? I can hear you.
Ms. Polk is asking, are these side effects permanent or will they stop?
They will eventually stop.
Okay.
It will eventually stop once your brain has gotten back into what's called homeostasis, where it's kind of at a place where, okay, we're good, we're withdrawing from the medicine, we're good, we're okay. Then you will find that it will subside. But sometimes it takes a while for it to do that, depending on the medication that you have and that person was taking, and depending on how abruptly the medication was taken away from the person. Sorry. All right. So that was what we were just talking about, the clinical barriers to success for medication treatment. Some people are afraid of the medication side effects, because there are some sexual side effects to all medications, especially those that deal with brain chemistry. You may find, I'll just be frank with you. This is what I tell my patients. You may find that it may take you a longer time to get to the O, or that the O never comes, or that the erection never comes, or it never goes away. So those are some side effects that you have to deal with sometimes with taking those medications, or abruptly snatching them away from your body. So you have to be very careful about that. People feel like there's a psychological stigma to taking medication. They're like, oh no, I can't do that. That means I'm weak. But I always tell my patients, this is me, that you don't have to tell anybody that you're taking the medication. Or they'll say, well, I feel like it's a crutch. Well, nobody knows unless you tell them that you're taking it. But still, there's a stigma there. There's some people that have a fear of becoming addicted, and that is a good fear, because there are some medications, like say Klonopin for one, that can be highly addictive if you take it for a long amount of time. I was just picking on Klonopin, but there's a whole list of medications. Or that I just talked about this, not taking the medication consistently, which I was talking about the brain zaps, where you just snatch the medication away from your body. Or there are people that take, this is another question that I ask my patients when they come to me and I'm their therapist. I ask them, I say, okay, so what's your drug of choice? Because there's usually, if you have a PTSD response, and that's your diagnosis, usually you'll find that if they are not medicated, they are medicating themselves in some other way. So my question is, what's your drug of choice? I'm just a very frank therapist. If you want to make a referral to me, that's just how I do it. And sometimes they're mixing alcohol with pills, or they're using marijuana, or whatever they're doing. But you have to understand what they're trying to do is self-medicate. They're trying to lessen the pain. They want to numb it. They want it to go away. They don't want to think about it anymore. That's what's going on. And so for me, I have a frank conversation with patients, because depending on what medication you're taking, some of this you don't need to be mixing clear and brown, and please don't mix this other stuff with that other stuff, because that's causes the problem. And now we got a whole another issue, and you need charcoal, and your stomach needs to be pumped. So you have to have a very frank conversation with patients, especially with PTSD, about what their medication of choice is. And sometimes it's not prescribed through a MD. All right, so there are so many clinical tools that are used to diagnose. The CAPS is one that the VA, Department of Veteran Affairs, they use that. There's an ACEs, the ACEs study is used just in general to talk with and to poll the general public about it. adverse childhood experiences. And here are some others that are used for self-assessment that you can Google and answer yourself. It'll generate it for you. But if you can take that to your mental health provider if you would like, or you can bring that to your first or second appointment if you would like, but that would help you kind of understand where your triggers are and what's going on with you. All right, so here's some that you can use for children. There are several, but we try to keep them kind of in a smaller area of what we want to use for kids, because kids are so impressionable. We want to get a good baseline for kids so that we know how to treat. All right, well, what can I do to help myself? There are so many things that you can do to help yourself. It is important for you to know that although it may take some time for you to get better, with treatment, you'll get there. There is no such thing as just 100% okay. You know, there may always be something there, but just know that it'll get better. You want to talk with your healthcare provider. You want to talk with your mental health provider. There are things that, people have said throughout time: exercise, deep breathing, I call it eat, pray, love. Love on yourself, please eat, and whatever moral compass you have, log into and connect into that. Try to maintain a routine if you can, and set realistic goals and be very realistic and be patient with yourself. I want to say, try to avoid using drugs and alcohol together, or prescription drugs and alcohol together. That is a recipe for disaster. That is a recipe for, people really getting hurt. But on the other hand, how can you help a friend? You want to be understanding, be patient, in offering your emotional support to that person, and be encouraging, even to encourage them to go seek out therapy or to talk with their, like I said, a mental health provider or a PCP, so that they can get some help that they need. There are a lot of people that are struggling in silence, and what happens sometimes is suicide attempts will happen, because people are trying to numb this pain that's going on, and they just want it to stop. So please, by all means, be patient with your loved ones that have a PTSD diagnosis. Believe me, if they could, they would stop the triggers. If they smelled peanut butter, they didn't have to smell peanut butter one more day, believe me, they wouldn't. Or if they didn't have to hear, the clicking that sounds like a gun, they would not. And I know it's a lot for some, but I'm sure that they appreciate all of your help and your care and concern for them. So I want you to remember about PTSD when making diagnosis and when thinking about people with PTSD is the acronym that was trauma. There has to be a traumatic event. There has to be a re-experiencing of that event. There has to be an increase in arousal, they're unable to function in some type of way. These symptoms have to have occurred for 1 month or more. And then there is some type of avoidance that happens with that. And I am stop shy, so I'm 10 minutes under. I wanted to ask, did anybody have any questions, anything that I can answer in more detail for you? Don't be shy. They're not.
I have several questions. Oh,
I
and
have several answers.
you have a few questions here. Ms. Dean is asking, are you seeing an increase in diagnoses since COVID?
Oh, PTSD? No.
Ma'am. No. And Ms. Morgan says, Dr. Brown, you are such a great presenter. I have learned a lot today. Ms. Madry says, great presentation. I have a question though, and it's this. In the beginning, well, two things. First question will be an easy question for you, which is, if someone like a friend or even someone you encounter, you think is experiencing the symptoms or the PTSD, do you I don't believe you don't ask them about their experience. Is that correct? You don't want to put them back through it.
You can. If you're comfortable with that person, I would. Because sometimes they
Okay.
want to talk. But I wouldn't dig. Right. So if you want to say, hey, it sounds like you're having a hard time, dealing with, that I'm just making something up, y'all, that carjacking. You want to talk about it? You can be a listening ear, but I would not dig like, well, what happened? And then what happened? And tell me what happened after that. And what did you do? I would not do that. But I would gently, as a friend, say, hey, would you like to talk about it? I'm here to listen. I would do that. One thing that I want to tell you, if you have a combat veteran, they are actively in a PTSD state. It is not a good idea to put your hands on someone who is actively having a PTSD crisis. Please, please, please do not put your hands on someone who has had that happen, especially if it was a violent situation. Because usually what they're going to do is they're going to try to fight their way out, right? So they're standing there, they're already thinking, oh my gosh, I heard the click of whatever. Could have been the click of a door. Somebody locked the door, but it sounds like the cocking back of a firearm or a sidearm is what military service members call it. Please do not put your hands on them because it brings them back. Remember I told you it could be a smell, it can be a taste, it can be a touch. Well, sometimes it's a touch and you literally touching them to set them off. It's even a young lady who has had sexual assault happen. If she is currently in that state where she's like, oh my gosh, I feel like I'm in fear right now. It's happening to me right now. I'm having this anxiety, this stress, and you put your hands on that person, you have connected the mind to the body, and you will usually see a fight, flight, or flee response. That person might swing on you. They might try to fight you. And you may take that as, hey, I'm just trying to help you. And you're fighting me. And you may want to fight that person back, or you may want to defend yourself. But put yourself in the mind of someone who is definitely afraid right now. And then you put your hands on them.
We have a follow-up to my question, which is Terrence Lash is asking, Dr. Brown, is there a proper procedure on how to handle a situation where I've noticed signs of PTSD in a person along with self-medication, but it hasn't become detrimental to them as of yet?
Is there a proper procedure? That would come in with talking with that person about seeking help from a mental health provider or seeing their primary care physician. That would be the proper protocol. You're saying that they are self-medicating. Depends on what their drug of choice is. Especially if it's something, I'm just going out there. If it's meth, somebody, might want to get somebody else involved with that. If it's marijuana, you still want to get somebody involved, but you want to talk to them always, whoever that person is, about seeking help and getting proper help.
And
yes, you can get a handout of this.
Okay. And then I have a question, a follow-up. And for those of you who are listening by phone or not seeing the screen or the chat room, today's password is all caps trauma, as in the acronym Dr. Brown shared. TRAUMA is the acronym for today, or excuse me, the password for today's evaluation, which is, I think all of you have the address. If not, let me know. But my question is this. In the beginning of our presentation today, I believe I heard you say that there is a new DSM-V disorder, which is post-traumatic slave disorder. Did I hear you correctly? And if so, what might be some of the things to look for, or what might be some of the effects?
Okay, it is not in the DSM just yet.
Okay, all right.
Dr. DeGru is working on that. That is a new diagnosis that
Okay,
has been coming around the pipeline. And what that looks like is it talks about generational trauma that is passed down.
okay,
Meaning, say for instance, I'll just make it kind of real for us today, being afraid of the police, or being running from police, running from authority, um, um, spanking of children, that those things have been passed down from generation to generation in such a way that was supposed to be a protective factor in the slave generation and those after. And then it has been used as residuals to kind of control behavior now. So it is not a DSM diagnosis. There is no ICD-10 code or ACPT-10 code for it just yet. But Dr. DeGru has been working with, she has great work on post-traumatic slave disorder. And it is a diagnosable DSM diagnosis. It's not in the DSM-5 just yet.
okay. And so what would you look for? I mean, would this be something that all Black people would really have?
Mm, possibly. What it looks like, what post-traumatic slave disorder looks at is how slaves behaved when they came here to survive, and what they
Okay,
did to pass that, and then the trauma that they experienced and how that was passed down through the generations. And so that's why I used running from the police as one of those things. Basically, the police would be a trauma stimuli, and the running would basically be the avoidance that you would be thinking, or getting pulled over by the police and seeing the lights in your rearview mirror would cause you hyper intensity and hyper arousal situations like that.
that's so fascinating to me. And so really it sounds like that post-traumatic slave disorder is sort of uh, the end point of the calculation of assimilation. Is that true? That by
Yes.
assimilating, people lose their culture and therefore they lose their way?
What it is they sometimes people behave in manners that they don't understand why they're behaving in that manner
Okay,
until there is an explanation of why it happens. So say for instance, one example that Dr. DeGru gave was back in slavery, there was a time for New Year's where that's why a lot of Black people go to what we call watch night service. It's because that was when families would be separated and they would be auctioned off to go to other places. And
oh my,
so if a slave owner saw a woman with her child and he said, that's a nice looking boy you have there, he's looking at the young boy to think about selling him off to somewhere else, right? Or using him for another purpose. Well, the mother would say, "Oh no, you don't want him. He's dumb. He's stupid. He's not strong enough. He's not this. He's not that." And although that mother loves her child, she's saying those things to discourage someone from selling him off into slavery. Well, generationally, what she said, what she was saying is that behavior has gone on throughout generations. So you'll
right.
have generations of mothers who love their children that will say, "Oh no," somebody will say, "Oh, your son is so nice and he's so this or that," and she'll go, "Oh no, you don't want him. That boy, he doesn't do anything I tell him to do. He's so disrespectful." Well, the thought is, it's been learned throughout generations to do that, to downplay children so that nobody will want to take them from you. Does that make sense?
Completely, yeah, it does. It makes complete sense. And I am someone who believes that trauma is and can be passed by generation to generation.
Mhm. Yes,
I
and
I
it can
really do.
happen not just in the Black community, it could have happened in anybody's community, in the American Indian community. Could be the same thing.
Right.
But this was just the work of Dr. DeGrew with her PhD program and what she looked at as far as she compared slave responses to responses of those that are of today, what they did then as opposed to what is done now and how they meet in the middle.
And Ms. Polk as asked, could post-traumatic slave disorder possibly encompass modern day slavery like sex trafficking?
No, because the trauma that we're talking about is race related. Now, if we were talking about sex trafficking of African American young ladies or men, then yes. But if we're talking about sex trafficking as a whole, then no. Sex trafficking is a trauma, and it could cause PTSD in the person that is being trafficked, most definitely. But we would not compare those two together unless the qualifier is race. So if we're talking about trafficking, just saying though, we're talking about trafficking young indigenous individuals or Hispanic individuals or Black individuals, then yes, we can compare them that way.
Okay, well, it's just been fascinating. I'd really like to hear more about this. If you've got anything not already on the shelf that you want to share with us, this to me would be a terrific topic. And then as you were talking, I'm sure you're familiar, but if you're not, and if other people aren't, I think one of the best ways to understand the sort of disassociation through literature would be Maya Angelou and her book, I Know Why the Caged Birds Sing. And it very, beautifully encapsulates her experience as a trauma survivor and going for some maybe years without speaking, and how she came out of that and addressed it, and of course became the celebrated author that she was. But it's a wonderful book, and if you like to read and you haven't read it, I would suggest it. Thank you, Dr. Brown, for being here. Ms. Bird said she loved this. Oh, I'm sorry, there's another question. We've got people hanging on with us late. Terrence Lash, I find this very interesting. I recall learning about the African-American way of life in early US history, where after a plantation had classical conditions, their slaves, the old slaves to teach the new ones how to live and conduct themselves. So could this new diagnosis be something connective? I thought for some time that trauma can be genetically passed down.
Yes, it can. And that is exactly what Dr. DeGrew's research was about, Mr. Lash. Thank you. That's exactly what the research is about, where you're teaching behaviors and patterns are being passed down throughout generations of people. And they're not knowing where that origin came from. They're just doing it because it is what we've always done.
It's fascinating. So again, I'd love to hear more about this. Of course, anything you have to say, I think we all appreciate, and the people have stayed late. See if I can find that. It seems like there's one new message. Thank you. I hope you will consider speaking on the PT Slave D in the future, says Miss Dean. Miss Bird says, love this. And I did too. Thank you. Thank you for staying over. It's been a while. Everyone, I think, is on the survey, the evaluation, the password. Any last words for us today, Dr. Brown?
Just thank you for having me again. I appreciate it. I don't know, I put my information up, so if anybody is in need of a therapist or I can direct you in the right way, then contact me so I can help.
Thank you so much. And if I don't have it, you may have sent it. Will you please send the presentation? And many people are asking for it.
Absolutely.
All right. Thank you all for a great session. Thank you, Dr. Brown, and y'all have a great week.